Well, just thank you for this invitation. We are very pleased and honored to participate to this meeting in Prague. The team, my partner, Benjamin Honton, we have the anesthetist Anne-Laure, the nurse is Emily, and Manon. So maybe we can now move and present the case. May I have the first slide? So we will deal with a complex LAD bifurcation lesion, but in an octogenarian patient, but you will see that this patient has other problem. So next, no specific past medical history, and the patient was sent to our center after an acute coronary syndrome, and the previous evaluation noticed that he has some mitral regurgitation murmur. So he was sent directly to the cath lab next due to an ongoing right chest pain, and on exhibition, a clinical exam, there was an intense systolic murmur. The ECG was normal with no specific modification, and in the center that have evaluated the patient before, they have done a transthoracic echo that showed that the ejection fraction was good, 70%, and there was effectively a mitral regurgitation, severe, with some mitral valve prolapse. So next, about the blood test, nothing special. You see that he has a normal renal function, a slight elevation of the troponin, and the proBNP remain in the normal range. So when we perform the angiography, there was some complex critical lesion at the level of the first obtuse marginal branch and the proximal circumflex, with also, but it's not clear on the view, that the second marginal was occluded. We see that on this spider view, this complex lesion at the level of the first marginal and the left circumflex artery. Next. This patient had also a long calcified lesion, severe on the LAD, involving a diagonal branch. It is a quite important diagonal branch. And finally, the right coronary artery has some disease, but it was mild lesion, so nothing to do on it. So the primary evaluation conclude that the culprit lesion was probably at the level of the circumflex and marginal branch, and the patient was treated immediately by PCI on these two lesions. Next. So what have been done is like an inverted T stenting strategy. Next. So after predilatation and after wiring and predilatation, a stent was put first in the first marginal branch. Next. Then opening of the circumflex. Next. Then stenting of the circumflex without protrusion in the left main, doing a kissing, and this is the final result, with a good result at the level of the marginal and the proximal circumflex. So after, the patient was re-evaluated by a transesophageal echo. Next. And this transesophageal echo concludes that he has a severe mitral regurgitation due to a degenerative disease with mitral valve prolapse due to a mitral valve chordal rupture at the level of P2. The LV function was good. So there was an team discussion. It was an octogenarian patient with severe degenerative mitral regurgitation and 3-vessel disease recently treated by PCI. And the conclusion was to treat this patient with MitraClip and then perform a PCI on the LAD diagonal lesion. The MitraClip have been performed on Monday by our partner Nicolas Dumonteil. He put one clip with a very good result. There was a trivial mitral valve regurgitation at the end. And the key and the topic of today is now to treat this LAD bifurcation lesion, complex calcified LAD diagonal bifurcation. So the question that we have to discuss is, do we need to do a debulking strategy for this lesion and a provisional versus two-stent strategy, because it's a quite large diagonal branch. So maybe before we go to what it has our strategy, we can review the cine angiography. So maybe Benjamin, you can comment the cine angiography.
So you can see this tight lesion of mid-LAD and bifurcation with two important territory. It's a Medina 111, and what we can see is the importance of the calcium, a massive calcified lesion, especially on the bifurcation. And so According to this key feature, we decide with Bruno to perform first a debulking with a atherectomy, rotational atherectomy, before going for a strategy. We will try in this octogenarian to stay with a one stent strategy, but we will see after the reopening of the thread on the diagonal.
So we see also the mitra clip. Huh? It's
and
evident
we see,
that we
of
have
course,
the mitra
the
clip.
mitra clip.
Maybe we can review the other view. We can see, okay, this just to show you the result at the circumflex and the marginal that is still good. And we see that the second marginal is still occluded, but it's not an issue. So now the topic is to treat this long LAD lesion. Maybe you can show our last slide about our strategy, please.
Maybe.
Next. So we will do this by a 6 French translator approach. We do a rotablation with a 1.5 millimeter burr. We will then wire the diagonal, then predilatation on the LAD, put a stent on the LAD, do a pot, and see what we have to do on the diagonal, provisional strategy, 2 stent if needed. And if we have still time, maybe we will do a final OCT evaluation. So,
hey, Bruno,
yes?
First thing is to know whether you can hear us.
Yes, perfectly. Have you heard also our comment?
La purge.
Hello, Bruno.
Hello, it's
This
Flavio?
is Flavio.
Yeah,
Yes,
nice to hear you, Flavio.
Hello, Benjamin.
Hi, Flavio.
We have Neal, Uren, and nearly 100 people in the room. So it's great to have you here and to discuss this case.
Okay.
Before I mean, we give you the time to work, but I'm sure that what you have proposed is a very provocative case, because until a few years ago, nobody would have thought to treat a patient totally percutaneously on the valve, on the coronaries. This used to be a typical surgical case of ischemic complication, probably on the mitral valve, so requiring a valve replacement or repair, and at least 2 or 3 bypass grafts. Now, the fact that you do this percutaneously, it's great. And I just want to see from our colleagues their opinion. I mean, whether some of you still consider that this patient should be treated with surgery. Raise your hand. Well, I tell you, only 1 or 2 people would send this patient to the surgeon. So it's great to see that what you are doing, it's in line with what we think and what we know, and the potentials of percutaneous medicine. It's amazing. Now, regarding the technique, I'd like to share with my colleagues here, if you agree with the rotablation first as the first strategy for lesion preparation and discalcified LAD. Raise your hand if you think rotablation is your choice in your lab to start with this case. We have nearly 30% of people. And does anyone want to say which is the alternative to treat this? What would you do? Some argue that shockwave could be a case. Neal, do you agree with shockwave?
Yeah, I think if you can deliver the shockwave balloon, it depends how tight that lesion is, because the problem the shockwave has is delivery. If you can get it there, it's very reasonable.
Okay. Bruno, Benjamin, what do you think about why you choose rotablation instead of shockwave?
Well, I think that you raise a very good comment. Shockwave could be done effectively because it's a quite large lesion. The limitation maybe is the length of the lesion, but it's not too long. I would say that maybe it will require 2 or 3 delivery at different steps. The only problem is actually in our center, we evaluate the shockwave in a trial. It's not available in the market for the moment. And in the trial, we cannot treat a bifurcation lesion, except if we do not touch the diagonal. So because it's a quite large diagonal, that's why we do not consider the shockwave, but effectively, I think that for this specific lesion, shockwave could be also a good solution, especially if the patient has some LV dysfunction, etc. Because we know that with the shockwave, we are away from all the complications like no reflow, etc. So effectively, shockwave could be a good alternative here.
And to go further in the discussion, we in Clinique Pasteur, when we have calcified lesion, we will use atherectomy as a first step to prep the lesion and not as a bailout strategy. Maybe we can test the burr, please.
So it's a 1.5 burr. Okay.
Very good point. I mean, another variable that should be considered is that rotablation is the safest way to address a bifurcation. I mean, I have, it's very infrequent. I have never seen a side branch occluding after doing rotablation. So this gives you the possibility of keeping this side branch open while the preparation. There is a question from the audience. If you consider testing the relevance, the functional relevance of this LAD lesion with FFR, or in a different way, or you just trust on the angiography?
Well, I think that here, Flavio, if we look at the angiography, it's really a critical lesion. So I think that there is no question. I think that, effectively we can do FFR, but I think that the lesion is really severe, calcified. So for us, there is no doubt about the severity of the lesion.
I personally agree. I didn't do FFR in this LAD. It's large territory and it's a tough stenosis. And the other question is when the circumflex artery was treated?
It was 1 week ago.
Okay.
1 week ago.
So this patient will go home with complete revasc and valve repair in one single hospital admission.
Yeah.
Great.
Yeah.
And for the purpose of the discussion on the surgery, this patient underwent an acute coronary syndrome. And we know the limitation of surgery in this kind of cases. If we discuss surgery for this patient, remember that he underwent a STEMI last week. So percutaneous is a good approach.
It's a perfect demonstration of treating the culprit and then performing reasonably complete revasc before discharge, which is offers the patient the best alternative.
So you start rotablation. We start rotablation here. You advance very gently the 1.5 millimeter burr. So we just touch for the moment the lesion. We didn't cross for the moment. So Benjamin,
I see that you have the new RotaPro system, which for you is you take it for granted. But not everybody has the new system. This is the great system without the pedal anymore.
Yes, that's right. We forgot to describe the system, but you see, we now have just the button. There is no button. So to activate the burr, we just have to push on this button, and then we advance gently, like it's just by picking motion. It's still the same technique, and you see it's quite gentle rotablation. The pressure is still good. There is no evidence at the level, no modification of the ECG. So I think that really it's, we are doing this very gently, not too aggressive, and it's the way, to limit the risk of distal embolization. So just doing that.
Did you cross the lesion with the rota wire, or you exchange your wire through a catheter?
Well, here we exchange with a fine cross microcatheter. Okay. And you see, now he crossed the lesion very gently. So he done one run, and I think that we will do 1 or 2 more runs to be sure that, like we call the polishing run, to be sure that the lesion is correctly treated.
Flavio, you have a huge experience of rotablator, and in our center we make very short running burr time to avoid complication. In your experience, do you think it makes a difference?
No, I think that the use of rotablation, it's the only way to treat some patients, and of course safety goes first, and the technique is very important. Doing short runs, controlling your speed, taking care, very nicely positioned distal wire. The wire has to be as distal as possible. This gives the system stability, and sometimes the wire comes back when you do the rotation, so it's very important that you take all these issues under control. After the bar has crossed, it's a good practice to go through and for a couple of times, but after this, you are ready for a balloon dilatation and stent implantation.
I have one question, Flavio, to the guys. Are you going to use a second bar, or what would be the decision that would make you decide on 1.7?
That's a good point. In general, we just use one burr. The rationale is really to just prepare the lesion, and then we will try to do a predilatation with, for example, a 2.5 millimeter balloon. If we have any waste, any problem with a 2.5 millimeter burr, at this moment we will maybe consider to use another burr, but normally just one burr. The goal is now not to treat the lesion with the burr, it's just to prepare the lesion in order to have a full expansion of the stent.
Okay, maybe we can retrieve. We make 5 running time with the 1.5 burr. I think there is nothing to left anymore. Please, you are in Dynaglide. So the interest of the Rota Pro is to perform atherectomy by your own, and so you have of course the activation button, but you have also the Dynaglide activation that you can address with this button, and you have the strike here, so you can retrieve the burr by yourself, and it's very much more easier than the previous strategy.
Yes. Another issue that might be, let's say, take it for granted, but when you do a bifurcation with rotablation, you never use 2 wires, okay? Only one wire on the vessel you rotate, and then you put the second wire. I think that after they remove the rotabar, they will put the second wire to protect the diagonal before the balloon dilatation, but never rotate on 2 wires.
That's a very good point, and that's a limit with the shockwave, because the shockwave you can use 2 wire, and so you can protect your diagonal if you want to use the shockwave. That's one of the utility and the safety of the shockwave, and so it's a discussion. But as you say, Flavio, we never see a side branch occluded after the rotablation of the main branch.
Yes. There are many questions, so I apologize for making all these questions, but it's nice to have this interaction. A colleague from Belarus wants to know which is the dual antiplateral therapy that he followed after the acute event and now before the PCI.
Okay, the patient has been treated by aspirin and ticagrelor since the beginning. It's our standard protocol. It started in the secondary center, and we follow this protocol. So he received aspirin and ticagrelor from the beginning.
Okay, another question: whether you are going to use now a non-compliant balloon or a cutting balloon?
We will not use a cutting balloon. I think that we will use a non-compliant balloon, 2.5 probably. Something like that.
I think that after you have done rotablation, you don't need a cutting balloon.
No. Have you some experience of cutting balloon after rotablation?
No, I once you use the rota, you don't need it.
No, it's an extra cost, I think, and I think that there is really no rationale to do that. Huh? If you have a quick,
I think this is a really good point you made, Flavio, and the guys made as well, is that with atherectomy, you don't lose side branches, whereas if you use the shock, plaque shift. So one of the benefits of atherectomy is probably reducing the risk of plaque shifting into the side branch.
This is very important. This is one of the reasons why side branches do not occlude when you do rota, because you are not pushing the plaque to the ostium, you are just polishing the lesion. But this will happen when you do the balloon dilatation. So this is why now we put the second side branch wire.
That's a good point.
Do you still perform laser PTA or
no?
PCA?
We don't have laser since a long time, I will say. We don't have it available in our cat lab. So I don't know. I don't personally. I have no experience with the laser. I think that my partner Jean Fajadet have done some case a few years ago with the laser, but we don't have it since a long time, I will say.
So Bruno, another obvious thing that our colleagues notice, you are going radial, are you?
Yeah, that's correct.
Yeah, this is very important. In France, I have the data from the Rota registry. In France, is 90% of rotablation is performed by radial. In Italy, we are about 60%. In the US, for instance, it's nearly 0% because they still use bigger catheters. And if you use a 6 French Medtronic guiding catheter, you can use safely the 1.25, the 1.5, and up to the 1.75 bar with no problem with the Medtronic guiding catheter. If you use the Cordis guiding catheter, probably you will have too much friction with the 175. But it's you perform 90% of the rota procedures with the 1.25, 1.5, and 175. So going radial adds safety to a patient who had already an acute coronary syndrome. He's on dual antiplateral therapy. He's not in AFib, is he?
No, he's not in AFib. Correct. So just to summarize what we have done,
as well, if you want to go to a 2 millimeter bar, you can use a sheathless guide, so a 6.5 French sheathless or up a radial, and that gets you a 2 millimeter bar if you need to.
No, with the 2 millimeters bar, you need a 7 or 8 French guide catheter. And you know, this is an important issue. I think that with the availability of shockwave, you really don't need a 2.0 bar, because that means that the lumen of your artery is huge. It's more than a millimeter and a half. So we use the 2.0 bar to treat left main of huge vessels. But now, I mean, if you have such a large lumen, you can go with a shockwave balloon. The shockwave will never cross a very tight lesion. So this is why you need the rota before. You need a 1.5 rota.
So just to say where we are, we have done the rota ablation. We have put the 2 wire, one in the Ghana, one in the LAD. Okay. We do the predilatation with a 2.5 non-compliant balloon. It's 20 millimeter of length. And you can see there is a very nice expansion of the balloon. There is no waste. For the moment, there is still the rota wire in place, because if we have, you know, some waste remaining, we will not have to replace it. So we wait of the result of the predilatation before removing the rota wire.
And I think that now it's a very nice point. Okay. Sometimes it happens that you put your balloon and the weight is still persistent. And if you have your rota wire, you can upgrade with a bigger bar.
Yeah, and one thing is important is when you will stent, don't forget to retrieve the rota wire, because we can use it as a body wire, as a cutting, the pore cutting, and stay for the preparation of the plaque. But when you use the stent, don't forget to retrieve the rota wire.
Yes, it's very delicate and it can be broken.
Yeah, that's
between
right.
The calcium and the stent.
So maybe we can now evaluate the result after predilatation. It's a 2.5 20 millimeter. So the next step will be then to I think it's the rota wire with okay, so it's okay.
The rota wire is out now.
Is out, yeah. Up. Attends.
Okay.
C'est bon. On peut retirer le ballon et le rota.
Okay.
So you can see on the first angioplasty, there is still a footprint. You can see on the 2.5, but after another inflation, you can see that the footprint is out. So I think the preparation of the bifurcation is actually good. What do you think about that? And we will make an angio to see.
Yes, we see the angio, and then we decide the stenting strategy. In the meantime, there is a question: do you keep the patient on ticagrelor for 1 year, or you shift to clopidogrel to save some money?
Yeah, it's a good question. This patient underwent acute coronary syndrome. So ticagrelor for 1 year, I think it's a good option.
Well, that's correct. Normally it's 1 year, but it depends also of the follow-up of the patient. If the patient develops, you know, some kind of minor bleeding complication, if he, you know, something like that, maybe we will have to switch to clopidogrel after 2 or 3 months. So normally it's 1 year, but depending of the clinical follow-up, it could be shortened and replaced by Plavix after a few months.
On peut faire une autre angio, peut-être Bruno, je n'étais pas dans le tronc.
Vas-y.
For who ask what, I mean, if you put your wire and your microcatheter does not advance, it's a very unusual event, but it might happen. There is a new microcatheter that you can torque, which almost always goes. If it doesn't go, what you have to do is to cross the lesion with your rota wire. Yeah. Which is painful because it's difficult to control, but in most of the cases, you will manage with a floppy rota wire, it will go. And this is the last option.
Yeah. It's effectively when you have difficulty to cross with the microcatheter, sometimes you put the microcatheter just in front of the lesion and you are able to cross with the rota wire. Mm-hmm. That's effectively a possibility. So now we have to decide about the size and the length of the stent. So I think that here, I think the artery is quite large. And I think a 3.0, it's okay for the distal vessel diameter. Yes. And for the length, at least 30, 34. What do you think?
Well, the balloon you used was a 20, and the lesion is much longer. I think that I'd put a 28 millimeters balloon. Stent.
Well,
I would go for 34. I think you want 34. To cover. There's a little bit of atheroma further down from the lesion where that small diagonal is, and I think you want to get coverage to that, or you'll have outflow disease.
30.
So at least 30 and probably 34.
Okay.
Just to cover that outflow disease, which otherwise you'll be into.
And also because we will do a pot, we have to consider that we need at least 10 millimeter before the bifurcation. So 34 could be a good option.
So we go on the 34 millimeters length, 3 millimeters diameter as your advice, and I think it will be the good length to cover all the plaques, especially on the mid LAD.
Let's see, maybe we have to go down, pardon. I think that
34.
Yeah, it's okay. I think it's okay. That's correct, 34. I think then 28 could be also possible, but we have less, safety in the proximal part of the bifurcation.
Mm-hmm.
Okay.
But both are, between both there is 6 millimeter. It's not a major difference. You are more precise than us, Flavio. That's why you are able to use the 28.
Any preference on the side branch wire? Hydrophilic, non-hydrophilic? It makes no difference.
For us, we don't make any difference because here, it's a quite short jailing. It's not a very long jailing part of the wire. So I think that here that's not a real an issue. I think that it could be a problem if you have some bending. For example, a 90 degrees bending, a very long 90 jailing.
Degrees.
Yeah. Sometimes it could be a problem. But
makes no difference.
For this, I think no difference, especially if you have a short jailing part of the stent.
So definitely you decided for a provisional stenting, so one stent in the main, and then we evaluate the second one. Does anybody think that this was a case for starting with a dual stent technique? No. Good.
No,
always
you agree. It's an octogenarian patient. I think that if the patient has only the diagonal branch, we will leave it medically.
Mm-hmm.
On peut faire un angio 358, s'il te plaît. So we use a Resolute Onyx 3 millimeters by 34 millimeters length. So the results is good. I think we have to improve the expansion on the mid LAD, but first we will do the pot.
Yes, with a 3.5.
3.5 and with a short balloon 8 millimeters. I think it will be good.
Yeah, I think 8 would be okay. 10 also. Because we have a quite longer. 8 is for the 28 millimeter stent.
So you can you comment about the dilatation of the side branch before the stenting? Is this something you do or you advise not to do?
The general rules is to avoid to touch to the side branch, before stenting. It's a general recommendation. There is some case where you performing because it's a very, very critical lesion. You have maybe sometimes some, reduction of the flow in the side branch. I will say that in my practice, I try to avoid to touch it in order to have not to face the problem of the dissection at the level of the side branch. If you predilate the side branch, you have to be ready to stent it first because you can create a dissection, and then you will have to deal to recross through the thrust of the stent and to manage the proximal dissection of the side branch.
Yeah, that's a good point.
But you can see that after the inflation of the stent, there is a slight shift plaque on the ostium of the diagonal, which is also calcified. So if we want to avoid trouble, I think predilatation before stenting is not good, as Bruno say. And I think the reopening of the strut should be gentle in this case to avoid dissection, which will mean a two-strand strategy with a calcified bifurcation on the ostium of the diagonal, which is actually not prepared. So we will try to go gently for this part.
Okay, so now it's okay.
On peut se mettre un zoom, s'il vous plaît. Et voilà.
So now we have deployed the stent in the main branch and we do the pot. It's the standard, Okay.
I think I have to retrieve millimeters.
Okay. Okay. So 8 is okay.
There is a question whether you use rotablation as the first strategy or you start with a non-compliant balloon, and in the case it does not open, you shift to rotablation. This is a question without answer.
Yeah.
Because you never know. It depends on how expert you are on using rotablation. We have a low threshold because you know that when you do the rota, all the procedure will be much easier. So if you consider rota as a problem, because you are not used, you are scared, your team is not familiar with the technique. What you will do is do in balloon, then it does not open, and then you do the rota. And this is not a good way to do. What I would advise is that you train doing rota in simple cases with the low threshold. So when you get familiar, you will understand that it's much better to do a first quick run with rota, and then the procedure is much easier than keeping this in the shelf only in case you cannot manage with balloon, because this will be the more difficult case. You will have a bifurcation, you have dissected the vessel already. So it's good that you plan your strategy in the beginning. And of course, the more you do, the more familiar you get. You will have complications, of course, but this is another issue. But in expert centers, we try to use it before the balloon once quickly, and this makes the procedure much easier with a much better final result.
Because someone also asked, would you not perhaps use an OPN, a Schwager balloon, the high pressure balloon, rather than rotablator?
Yeah, it may work. The point if it doesn't work. And you never know that. Sometimes lesions that look terribly calcified, they open. And sometimes lesions that are just fibrotic with angiographically not too much calcium, they don't open. So in the doubt, probably I think that in this case, I agree with the decision of going.
That's a good point, Flavio. I think that with experience, we know when we have to use the rotablation. I think that, when you have difficulty to cross with the wire, when you have difficulty to pass with the balloon, you know that at the end, if you do not use the rotablation, you will have a lot of difficulty. So from the beginning of the procedure, when you feel resistance, in your hand when advancing the wire through the calcification, it's probably an indication that rotablation is a good solution. When you have difficulty to cross with a semi-compliant balloon, then you know that you will have to use a rotablation.
So you can see that I have some difficulty on the ostial LAD, which is very calcified, and I feel it with a stent, and you can see that the guide wire have some.
So now you try to recross through the diagonal. Huh?
So first of all, tell me.
Yeah.
Which wire are you using, Benjamin? Someone from the audience wondered which wire would you use to recross?
Oh, so my first choice, and I like it, is a Fielder FC to recross the strut. I think it's a very good wire, quite safe, and this is my first choice for recrossing struts. So as we go for a T provisional, we have to go on the distal strut of the bifurcation test.
But it might be, I am a little bit provocative, it might be that you don't need to recross and dilate, because the result might be already quite good like this for an 84 years old man. I mean, if you take two projections and you like it, you don't need to recross.
I think it's not provocative, it should be wise solution. It's not provocative.
So
it's a discussion that we had at the beginning with Benjamin when we discussed of the case, what will be the strategy, and I was a favor really for provisional strategy, because I say that we have done in this patient a lot of work, and we have a very good result on the mitral. We have done a very good result on the left circumflex and marginal. We have a good result on the LAD, and for me the diagonal is not really the main problem of this patient, except if there is a reduction of flow, etc. So now you remove the gel wire to explain what you are doing.
Yeah, I disengage, of course, the guiding catheter, because the wire is gel, not on a long lesion of jailing, but you have to be very carefully to retrieve the gel wire, not to engage, of course, the guiding in the left main, and avoid the distal dissection of the right main. So very gently you pull back the gel guide wire, and after, when it is free, you just take all your three guide wire and go back on the left main with the guiding.
Okay. So now the options are there. We have the two wire. The wire now has been exchanged, and we can do a contour angio and decide if we do something on the diagonal, yes or no. Okay? Okay.
So why I would go for kissing, but there is no truth. I think we have to expand a little bit the stent on the mid LAD, with a non-compliant balloon, and I think that the risk is to have an increasing of the sheath plaque on the ostium of the diagonal. So that's why I would go for kissing in this case. Of course, I'm particularly in line for this diagonal on an octogenarian patient. This is not prognostic, so but try to avoid to occlude it. What do you think?
Yeah.
Maybe we can ask to our colleague and attendees what they will do. We have everything is possible. We can stop here. We can. I think I fully agree with Benjamin that we need to postulate the mid LAD. For the diagonal, the door is open for every solution.
So we can ask to raise your hands if you agree on putting a balloon and making a dilatation of the diagonal. I think it's less than half. And the others, I mean, are okay. You are satisfied with this result? Yes, most of our colleagues are happy with the result. I agree with Benjamin. If you want to dilate a little bit more the LAD, where actually the most tight part of the lesion was, you see that the stent, it's a little bit underexpanded. So if you want to do this with a non-compliant 3.5, not only in the pot, but in the after the diagonal, you have the risk of having a shift and impairing the diagonal. So in this case, what I would do is putting a 2.5 balloon to keep the diagonal low pressure for 5 atmospheres, and then go in with a short balloon below the diagonal for a further expansion.
In fact, we will use a 2-0. We will be less aggressive.
2-0. Yeah. Okay.
Yeah, I mean, I think you can do either way, really. I think the question really is, at the end of the day, how much myocardium is the diagonal going to, and does it make the patient ischemic? And I think if you post-dill the LAD and the patient has TIMI 3 flow and they have no symptoms related to the diagonal disease, you're probably okay.
Yeah, I fully agree with you. I think that clearly here, I think that my first choice will be to post-delay the LAD, and if the result on the diagonal is stable, not to touch it.
Yeah.
But someone wants to know. It's a matter of preference.
Yes. Someone asked if you would consider to do IVUS on the diagonal. I mean, the use of imaging in bifurcation is advised. Is absolutely advised in left main. I wouldn't do the IVUS in this diagonal, but it's good to do IVUS at the end of the procedure on the main branch. And if you want, you can do it also on the diagonal. But I think, Bruno, that when you presented your strategy, you plan to do a final imaging.
Yeah, that's right. Yeah, okay. Because it's so calcified, we will do okay.
Yes.
If we have time, because sometimes, with the live, we never know if we have enough time. But for the moment, it's okay.
It's okay. Yes.
Okay.
Our colleagues want to know if you have tricks to avoid bar entrapment, which is, of course, the nightmare of the operators.
I think that the tricks is to never force. When you are hearing some resistance, when you are hearing the speed that is going down, at this moment you have to go back and to stop. I think the burr entrapment is when you are jumping, when you are forcing on the lesion, you are jumping, and sometimes you are surprised of the jump and you stop the pedal, and that's why you have the turb. That's arrive, I think, at the beginning of your experience, because sometimes you are a little bit, you have some fear when you see the jump of the burr through the lesion, and you stop the rotablation. I think that if you are really gently, we are doing very gentle, just picking motion, and if you are hearing the reduction of the noise, that means that you have too much resistance and you have to going back and to stop.
Yes. So being very patient, doing short runs many times, never pushing. If you see that the bar does not cross, it's not that because you push, because it will go, but then it doesn't come back. So very, very gently, just picking. And the other thing is, I would advise you to avoid doing rotablation in severely tortuous vessels, because tortuosity is the most dangerous feature of
sharp angles.
Very sharp angles.
So as you see, I performed the kissing with 3 millimeters on the mid LAD, 2 millimeters on the diagonal, just to open the strut and to be gentle on the ostium to avoid staining. And we will, as it mentioned by the ABC Club, we will do a report to avoid presence of strut on the bifurcation. and make a final angio and probably
we have time to do the OCT.
The OCT to be sure that the stent is well expanded in the LAD and well opposed.
So just to recap, now we have done the kissing. It's 3-0 on the LAD in accordance to the distal diameter and 2-0 a little bit on the size on the diagonal in order to limit the risk of dissection.
Okay.
So
Benjamin,
nothing has changed. So it's
great.
okay.
When you use the balloon to dilate the side branch, you used it always as a kissing technique, or you can just dilate with a single balloon and without kissing? This is a question from our audience.
As a pod side pod technique, as you say.
No, if you use kissing, two balloons, or you can just consider that one balloon on the diagonal and that's it.
If I go for one balloon in the diagonal, I will go for the technique which is called pot side pot. And so, but I'd like to do, I was training when I was younger by kissing approach. I think it's important, especially if we want to avoid the expansion, a mal-expansion on after dilatation of the side branch of the main stent. So I'd like to do kissing. I'd like to do kissing with non-compliant balloon, which is sometimes is tricky to go in the, especially on calcified lesion for the side branch. But I always go for kissing when I want to open the strut on the side branch.
I think actually there is no clear answer about the sequence of doing side branch then report. What we know is first, if there is two stent, kissing is mandatory. There is no question about that.
A new one.
Yes.
And if we do the side branch inflation dilatation, then we do a report after. So I think that the question is, do we need really to do a kissing, yes or no? There is some argument for pro and there is some argument con. For the moment, we don't have any clinical evidence of the advantage of the two techniques. After, it's a matter of preference. And I will say that for those who are trained with the use of the kissing, well, sometimes they are doing more kissing, and those who are used for the pod side pod, they are doing the pod side pod technique. But what is really important is if you touch to the side branch, then you need to report the main branch. Do not touch only the side branch.
Yes. And how much pressure did you give to the diagonal?
I think it was 14 atmosphere.
14.
Yeah.
So high
with
pressure
with a 2 millimeter, with a small one non-compliant. On peut se mettre un zoom, s'il vous plaît.
We have a question from a colleague in Kiev in the Ukraine who's asking, when would you consider using a drug-eluting balloon in a side branch?
Well, that's
something you do? That's an interesting question.
No. In general, we do just, with a standard balloon. I think that if we think to the mechanism, I think the mechanism of the side branch lesion is often you have a lot of recoil. So if you have some recoil, I'm not sure that, we will have a very good result with the drug-eluting balloon. So it's something that you can do if you don't have too much recoil. Mm-hmm. But for example, we know that, and Flavio knows that when we treat, for example, right corneal ostium lesion only by balloon, that was more than 50% of restenosis just by balloon. So I think that it's a really some lesion where we have a lot of recoil, and sometimes the drug-eluting balloon will not solve the problem.
So I think that the result on Joe is quite good. Maybe we can go further with OCT.
Well, we can ask. We have done the pot and the final pot. We have this result. There is still the question to stent yes or no the diagonal. Personally, I will not do it, but we can ask to our colleagues if they will do it yes or no.
Yeah, we ask. Raise your hand if you think that a stent on the diagonal would offer any advantage to this patient. Good to know that there is no one thinking that another stent adds any benefit.
Would anyone use a pressure wire or IFR? Would they use a functional test? Should we ask that question?
Okay.
Would anybody use a functional test here to assess the diagonal? So a pressure wire.
This is a nice question because it has been clearly demonstrated that pressure wires through the side branch after stenting give absolutely no help. Anything you get has nothing to do with the clinical outcome. So most of the highest lesions are negative.
Because they're going to small areas of myocardium usually.
Yeah.
And may I ask maybe another question? Do you think that 50 milligram of atenolol will be less effective than a stent for this diagonal lesion?
Of course. Medical therapy, it's on the basis of anything we do on the corners, of course.
I think that probably here I agree that if you do a FFR, it could be, it could be. Maybe we can remove the diagonal branch now. Yeah. What do you think? It's a problem. We do.
Doing an FFR, the FFR wire is not the best wire. So the only thing you risk is to have a dissection on the ostium, and then it doesn't matter what you measure because it has no clinical implication.
Okay. So we will go for OCT.
We'll do now the OCT. So we follow our initial strategy, except that we have done just a provisional strategy, doing a kissing. But now what we want is to evaluate the final result and to be sure that the stent is... Pardon? The stent is well opened, well apposed. Okay. So, okay.
Parfait.
Is it enough or a little bit? I think it's okay. So now it's a tough job. We don't have the injector, so I have to inject the dye. That will be tough for me.
By hand?
Yeah.
Wow.
On se met en mode OCT?
Yeah.
Mode OCT, s'il vous plaît.
Okay. On met en mode OCT. Ok, vous avez fait le truc. Ok, vous l'avez.
Ok, on calibre. So that's why it's Bruno who is doing the injection, because he's much more muscle than me. He's a rugby player, so...
Like you, yeah.
Activez le retrait.
Ok, activez le retrait. Vous pouvez le faire derrière sinon. Ok, c'est bon. Appuyez.
Attends que je... Attends.
Well, the opacification is great.
It's perfect, huh? Like an injector. Bruno is as strong as an injector. Perfect. So I think we will have some information.
We don't see any distal dissection first. Huh? The stent is well apposed. We see the apposition of the stent. This was probably the diagonal. We see the diagonal. And this is the proximal part. Maybe we can review. Huh? Maybe Flavio, if you have any comment. But when we look this first run, it seems...
What you see clearly is that all the length of the stent is well dilated, that there are no struts malapposed.
Yeah.
You see a lot of calcium on the artery wall, which is 180 degrees from 6 to 12. And I guess that you can also see the ostium of the diagonal, which was one of the questions.
Around 30,
you'll be able to see.
Avancez encore. Okay. Maybe here or
we have the core registration, so we can have this information.
Yeah.
Maybe we can nice the core registration, please.
Yes. It's a very nice image, and the fact that they dilated the ostium of the diagonal, you see that there are no struts on the ostium of the diagonal. And the question why report after the dilatation is because what you want to make sure is that the proximal part of the stent is well apposed to the artery wall. This is one of your questions. So each time you dilate the side branch, you have to report.
That's a very important point. What I want to, when we are waiting the core adjustment, I think I want to see the proximal strut. Because maybe on the proximal part of the stent, there is some slight struts which are not well opposed. We will see in few seconds.
We can see where we are with the point. You see the dot on the screen to the left part of the screen, and we see we go back. We will arrive now to the go back. I think. No, plus haut.
Okay, this is the ostium.
There. I think we approach the ostium. Probably it should be avancer.
Enlevez la mesure de surface, s'il vous plaît. Laissez-nous voir les struts.
Ok. Non, enlevez ça, c'est pas la peine. Enlevez ça.
Voilà.
probably there is one strut that is not touching the wall. I mean, you know,
but I think it's not really a problem.
No, le mieux,
I
c'est
will
de
not.
limiter
You
bien,
see
hein,
here it's the
yeah,
bifurcation.
yeah. You can see.
You see here we have the bifurcation.
Just in front of the bifurcation.
The dot is exactly at the point of the bifurcation, so we are sure that we are. And I think that the opening of the diagonal branch is okay for me. There is nothing.
Yes.
I'm not sure that the stent will improve the result. They could improve the ostial lesion that was there before, but the opening of the strength at the level of the ostium is quite nice, huh?
Yes. I absolutely
and we don't
agree
see
that
any
this
proximal dissection also. I think that for me the result is okay. Huh? I will accept this OCT evaluation and also this angiographic result.
The question to both of you guys, do you perform this routinely or the OCT, or is just because of this live transmission?
No, it's because of this live transmission. To be honest, in our clinical practice.
I want to make this clear. Don't think that we do.
We don't
like
need
this
OCT to perform this lesion PCI. I think that it was here the opportunity of the live transmission to do it. I think that we are using OCT. For example, when we have any doubt after the initial angiographic result, what is important is to have first a perfect angiographic result. If you don't have a perfect angiographic result, you don't need OCT to see that the stent is not well apposed. So really, you have to go back first to the angio. If you have a very good angiographic result, we rely on this, and we are not performing OCT. If we have any doubt, some strange image, etc., sometimes we are doing an OCT to understand.
But we can discuss it in the left main. In the left main, it's mandatory to perform a final endovascular imaging.
But we are not doing.
But we are not doing, aren't you?
Okay.
Yeah. There is a trial run by Adrian Banning, who is going to start by the mid-term of this year, which is randomization to angio-guided and IVUS-guided PCI on the left main. Because left main is indicated in the guidelines with a 2A recommendation, but it's not a one recommendation because there is no randomized trial. So this will give an answer. But in practice, I think it's always very good to have a final look, especially in complex left main lesions.
Okay, so maybe we can do a final angiographic result, and to show you this result and accept it.
On va se mettre un zoom.
Ça y est, on y est. Okay.
Okay, well, it seems not too bad.
I think it's quite a good result if we consider the calcification of this lesion. I think that if you agree, we can stop here and the procedure. The strategy was to do a rotablation because it was calcified lesion, and it was to stent the LAD and to be provisional on the diagonal. I think that we have done it. We have done an OCT at the end to be sure that the result was good, but the angiographic result was really good, and the angiography and the OCT confirmed that there was no evidence of real stent malapposition. I think that we can accept this final result, if you agree.
Well, of course we do, because when you can stick to the plan A, that means that the plan was correct and everything went as expected, which is the best way to work. And if I want to remark again, something that I find really overwhelming is treating these complex old patients totally transcatheter medicine. The valve, the circ, the culprit lesion, the complete revascularization, the side branch, the final imaging. It's amazing all the potential we have to take care of these patients. I mean, the alternative was sending this 80-year-old man with 3 vessels for bypass and a plastic in the mitral that then becomes a prosthesis, which has, of course, much more, might have at the long-term a benefit, but he will not live 20 years. So when you balance the risk and the benefits of our therapies, the age of the patient is the key issue. Neal, do you want to comment before we close?
I completely agree. I think you have to decide your strategy very much on the patient sort of individual situation rather than just have a blanket approach. And you're never going to put an elderly patient through major surgery when you can fix it percutaneously.
Yes. So we are perfectly on time. Okay. I don't know if you have other questions to address to Bruno and Benjamin before we close. Yes, we have one.
Lesion in the LAD is not significant.
They want to know about your evaluation of the proximal lesion of the LAD before the stent.
Yeah. I think that for us it was, not critical lesion. It's, an old patient, and you have also the lesion of the, of the LAD. I think that it's an octogenous patient. We have done really some job on the circumflex, on the mid LAD, on the mitral valve. We can now follow the patient and see what is the clinical course of this patient. I think that for the moment, I think we have done what was really important for him, and we will follow it, and we'll see if there is something more to do.
I totally agree. I would do the same. If the patient comes back in 2 months saying, I am still jogging and I have chest pain, then I would consider. But for an 80-year-old man, having another 20 millimeters of stent is much worse than having a 50% lesion, or even having a chronic angina at a very high workload. I would avoid to put more metal in the patient. And the last question is, how long will you keep him on dual antiplatelet therapy?
I think it will be 1 year, for sure 1 year.
1 year?
I think, but once again, it depends of the clinical follow-up. If the patient has some problem, hemorrhagic complication, then we can shorten, but normally the rule is 1 year. It's an acute coronary syndrome. He has 3 stents. He has the mitral clip. I think that 1 year is really what we will do for this patient, except if he develops some bleeding complication.
Okay, thank you very much.
Thank you, and I think, and we want to thank you once again for this invitation. All the team was really honored to participate to this meeting, and I hope that we'll enjoy the end of the meeting. And I know that tomorrow morning our partner Nicolas Dumonteil and Didier Cheche will do a TAVI case. So have a nice meeting, and see you in Flavio.
Thank you very much,
guys. Well done.
Thank you very much. Thank you.
Bye.
Okay. What's next?
Breakout session.
Merci.
Breakout session. There was a colleague. I mean, you wanted to make a question. You can make the question anyway before we leave, because
La sélection du cas était très importante.
J'en ai fait l'expérience tout à l'heure.
Bon, tout s'est très bien passé, monsieur Laudet.
Super, impeccable.